Good evening, everybody. Thanks for joining me for this webinar tonight on upper respiratory tract disease in cats. Topic about a very common problem that we have in feline medicine, a problem that we see really in every country around the world. So in honor of our topic tonight, I decided to wear my Hello Kitty t-shirt. You see my Hello Kitty t-shirt? I'm a big Hello Kitty fan, so I thought I'd wear my t-shirt for you for this evening. So we're going to spend this evening, next hour or so, talking about various aspects of upper respiratory tract disease in cats. It's actually a pretty big topic to consider. And so we're going to be covering for tonight a few key aspects. So I'm going to show you some resources. I'm going to show you first a couple of resources that are online that I'd like you to have a look at if you haven't already seen. And I'll show you at least one other resource as we go through our webinar tonight. Then we'll spend some time talking about the clinical signs. We'll talk about some of the causes, and we'll actually spend a little bit of time talking about some of the individual pathogens that we see, because that directly leads into topics about proper diagnostics and when we would use diagnostics, and then also therefore about treatments. So we'll kind of link all of those things together tonight in our topic. Well, the first resource that I wanted to show you is this website, the European Advisory Board on Cat Diseases. So if you haven't seen this already, then I would recommend that you have a look at this. This is a website that is specifically about infectious diseases in cats. And they have all of their resources online for free. And you'll see that there is a section called Fact Sheets and Tools. It's where the red arrow is. I'm pointing you to that section. If you click on that link for the Fact Sheets and Tools, you will see all of the individual disease fact sheets. There's about 45 of them, as a matter of fact, 45 different topics in feline infectious diseases, and many of them have been translated into different languages. So specific to our topic this evening, they have translated some fact sheets on herpes virus, calicivirus, bordetella, chlamydia, into Hungarian. So there is a variety of European language translations available for several of these topics for you as well. So if you haven't already seen this website, I encourage you to go ahead and have a look. It's very informative. They do keep it up to date. So it's often the first place that I will go when I'm looking for current information on a feline infectious disease. So I just want to remind you that there are three key components to upper respiratory tract infection in cats. And we're going to spend, of course, some time talking about the pathogens themselves. We're going to talk about herpes virus, calicivirus. We'll talk about chlamydia, bordetella, and mycoplasma. Those are the main ones that we'll be talking about this evening. The second key component is the host factors, and these have to do with the age. So we often see more severe disease in kittens, for example, in cats that have a concurrent disease that they're already struggling with that might make them a bit debilitated, and then sometimes in older cats too that may not have as good immune function as they did when they were younger. So there are factors independent of the pathogen that are specific to the cat itself that can influence whether a cat gets an infection, and if they do, how severe it is and what the clinical manifestations are. And then the environment also plays a role. So we certainly see different manifestations of disease often, and different severity in situations that are very stressful. So overcrowded situations, shelters, for example, rescue situations, people that have too many cats in their homes. These are very stressful conditions for cats, and that type of chronic stress does have an impact on the cat's immune function. So these cats may not have as good immune response as they might otherwise. And of course, there's often a variety of infectious diseases and other diseases in environments like that, and maybe even nutritional status isn't as adequate as it should be. So these are some of the factors that we have to consider when we're looking at these topics, particularly for upper respiratory tract infections. And we're going to spend most of our time tonight more concentrated on the pathogens themselves and the diagnostics and the treatment for these pathogens. So as we think about these different pathogens, I want to remind you that the clinical signs are quite non-specific for upper respiratory tract disease. We'll talk a little bit about how you might raise your index of suspicion for a specific type of pathogen. But most of these pathogens produce very similar clinical signs in cats. So we often see fever, lethargy, some degree of impact on appetite, sneezing sometimes accompanied by nasal discharge or ocular discharge, and various degrees of things like conjunctivitis, maybe ulceration, whether it's on the cornea or in the mouth. If it's in the mouth, we often see some salivation. And with a couple of these pathogens, specifically herpes virus, because that can give us a tracheitis, and with Bordetella, we might see cough as part of the clinical picture. And of course, the clinical signs vary from mild to severe. So we'll see often, again, more severe disease depending on host factors. So in kittens, cats that have not been vaccinated, cats that have other diseases, senior cats, and so on. That all of those factors, host factors and the environmental factors, can influence just how severe the clinical signs are. I did want to say a word about unilateral versus bilateral nasal discharge. This is one of the things that I pay attention to when we see cats with upper respiratory tract disease signs. If we see specifically unilateral discharge, I always want to make sure I'm considering some of the other causes that are not infectious causes. So, for example, I might think about neoplasia if it's a middle-aged or older cat. I might think about a foreign body. I might think about a tooth root abscess. So those are all situations where we might more typically see a unilateral discharge, as you can see in the two kitties in this picture. So for example, this cat has unilateral discharge, sort of a brownish, like a serosanguinous discharge. And this cat turned out to have a tumor called an odontoma, kind of an unusual tumor, but it highlights the point that these unilateral discharges often are associated with non-infectious causes. There's another kitty, unilateral discharge, so that could be a foreign body, that could be a tooth root abscess, it could be something like that. So it doesn't mean it couldn't be infectious, but it means that I do want to keep some of these non-infectious causes near the top of my list as I'm going through the diagnostics for these cats. So I said that we could look a little bit at clinical features and move one or other of these pathogens higher or lower on our list. It's often very difficult to know exactly which pathogen is at play. So, for example, herpes virus and calicivirus, they will make up 80 to 90% of your cases. We may see some secondary bacterial infection in there, and we'll talk about the three other causes on this list individually, because we can also see primary infections with those bacteria. But herpes virus and calicivirus will make up 80 to 90% of your cases. So one of the key differentiating clinical features between herpes and calici is for herpes virus, we're a little bit more likely to see corneal disease like corneal ulceration. We're going to look at some examples of that in a few minutes. And with calicivirus, we're more likely to see oral ulceration. Remember, though, that cats can have both viruses. So there's no law that says they only get one of these infectious diseases. They certainly can get more than one. We're more likely to see conjunctivitis with calicivirus. Doesn't mean you can't see it with herpes virus, but we're more likely to. Same with stomatitis, a little bit more likely to be involved with calicivirus. Facial dermatitis, which we're going to talk about separately, is something that we see specifically with herpes virus, although we can see some skin lesions with calicivirus in cats that have a more virulent form of the disease. And we're going to talk about those aspects of those viral infections in a little bit more depth. When it comes to the bacterial causes, one of the highlights here is Bordetella. So cats that get Bordetella infections are more likely to present primarily with a cough, maybe with some rhinitis, but coughing would be their key feature. And when we have primarily conjunctivitis with few other respiratory signs, that makes me think of chlamydia or mycoplasma. So you might get an idea one way or the other, depending on the clinical presentation, of what might be the likely primary pathogen for your patient. But bear in mind, we can be wrong, and we also see mixed infections actually quite commonly. So, reminder again, though, that 80 to 90% of your cases are going to be caused by herpes virus or calicivirus, and then potentially with some secondary bacterial infection, which we're going to talk about. Okay, so I'm going to go ahead before we start talking about the bacterial aspects and send you the first poll. So let's see if I can get the first poll up and active for you here. So what is your preferred antibiotic for your patients with upper respiratory tract disease? If you're going to reach for an antibiotic for a patient, which is the one, I know I only gave you 4 choices, but they're common choices. So would it be doxycycline? Would it be amoxicillin? Would it be erythromycin? Or could it be a fluoroquinolone of some kind? Because there's a variety of fluoroquinolones on the market. Different ones in different countries. So I didn't list a specific fluoroquinolone in there. So let me know what you would pick. And then I'll tell you what the current expert guidelines would recommend. But I'm kind of interested to see in general what you would pick. And usually when I ask this question, whether it's in a webinar like this or in a live audience, I'll get a variety of responses. Okay, so let's go ahead and end the poll here. And it looks like a few of you would pick doxycycline, but the rest of you pretty evenly split amongst amoxicillin and erythromycin and a fluoroquinolone of some kind. Okay, so we'll go ahead and talk about how we might pick an antibiotic and what type of things would play into that decision. So one of the first things that I wanted to talk about was acute versus chronic disease. So, and we define that by duration. So acute disease is a patient who has had clinical signs for 10 days or less. So we may handle those patients a little bit differently. They are much more likely to have viral or bacterial causes of their disease versus some of the other things we might see with chronic disease, like a foreign body or a tumor or something like that. So these guys are more likely to have primary infectious disease, viral or bacterial. And we're going to treat them with supportive care. We'll talk a little bit about that in a minute. But as I'm going to show you the current guidelines for upper respiratory tract disease, and it's recommended that your first line antibiotic choice be doxycycline. And doxycycline is picked because it is the antibiotic of choice for chlamydia, Bordetella, mycoplasma, which are 3 of the common pathogens that cause upper respiratory tract signs in cats. And it's a fairly broad spectrum antibiotic. So we might reserve the fluoroquinolones for different cases, as we'll see in a minute. We'll talk about the chronic disease patients. I would say your second choice in that acute disease situation would be amoxicillin. So not amoxicillin with clavulanic acid, but just plain amoxicillin. We often overlook how useful just plain amoxicillin is. And that will work against a lot of pathogens, not as broad a spectrum as doxycycline. So that's why I would say doxycycline. And we'll typically dose cats at 10 milligrams per kilo per day. And in that acute disease situation, we would treat for 7 to 10 days. So those are the current guidelines. We're going to talk more specifically about treatments for herpes virus because of the viruses. That's the only pathogen where we have specific treatments. So we'll talk about the using lysine. We'll talk about the antivirals in a moment. So that's acute disease, cats that have had upper respiratory tract signs for less than 10 days. Chronic disease is defined as clinical signs for 10 days or longer. And of course that could be weeks or months. Then, yes, they still can have infectious causes, and we'll talk specifically in a minute about how herpes virus can set up long-term clinical signs in cats. But now we also have to be thinking about respiratory signs that are actually caused by non-infectious causes like foreign body, maybe nasopharyngeal polyp. We'll look at that in a few minutes too. Maybe a tooth root abscess. So a good oral exam is really important in these cases. In the middle-aged and older cats, we think about neoplasia. So these cats typically have been on a course of initial treatment, and it may be an antibiotic, maybe some other treatment, but they have failed to respond, and so now they're a chronic case. So they do require more in-depth diagnostic workup, and we'll talk in the last section today about what those additional diagnostic workup options would be. In the meantime, we would now reach for a different antibiotic choice, and this is where the fluoroquinolones like pradofloxacin would come in, clindamycin because it penetrates bone very well, maybe azithromycin. I'm not a huge fan of azithromycin, and one of the reasons I'm not a huge fan is because that's a drug that's used commonly in human medicine, and we have to be very careful that we don't overuse or pick a drug that's relied on a lot in human medicine. And for some human pathogens, it's one of the few drugs that will treat some human pathogens. So I'm just keeping an eye on that bigger One Health picture of not inducing antibiotic resistance. But it's on the list. So you could use something like one of those drugs as your next line of treatment once we're into chronic disease. And then the length of treatment there is really 1 week past resolution of clinical signs, however long that takes. In North America, we sometimes use intranasal vaccines. I'll talk just briefly about that, and then we'll also talk about interferon use in these cases as well. So I divided up into acute versus chronic disease because our approach is going to be different. Usually with the acute cases, we may not even do any diagnostics. If it looks like a very straightforward garden variety case, we might just go ahead with supportive care if antibiotics are indicated, and we'll talk about what that is in a minute. I would recommend doxycycline as your first line choice. And then, of course, if we think herpes virus is involved, we'll use a herpes-specific treatment. Versus the chronic disease cases, we're going to be much more diagnostic workup focused, and then we're going to change our antibiotic choice in those cats as well. So that's why I divided up into acute versus chronic disease. So I did mention supportive care, especially for the acute cases. They might need fluid therapy. Some of these little kittens, especially sometimes even older cats, with acute disease have not been eating and drinking. They have fluid losses, so they might need intravenous or subcutaneous fluid therapy. They might need nutritional support. Often the little kittens are very congested, so we have to keep their nasal passages clear, and we might have to hand feed them. Older cats might need an appetite stimulant like mirtazapine, for example, to get them eating. We might need to treat a fever in these guys. If they do have oral ulcers that we can see with calicivirus, remember that that's painful. So I would add in analgesia, maybe something like buprenorphine, for example, as an analgesic. So never underestimate the pain component to upper respiratory tract disease. So I will use analgesia if we do have ulceration present, whether it's ocular, like corneal ulceration, or oral ulceration, or with very severe disease, even without ulceration. So I just never want to underestimate the probability that there's a painful component. I know traditionally we don't think of upper respiratory tract disease as painful, but I think there's a role for pain management in some of these cases. So let's bear that in mind as well. So that's supportive care, and we've talked already a fair bit about antibiotics. When would I use antibiotics? When we have evidence that they're needed. So typically that's going to be a patient with a mucopurulent discharge. So a patient like this one, you can see this patient, for example, has a mucopurulent bilateral ocular discharge. So when we see that, then we know we either have a primary pathogen that's causing the mucopurulent discharge. Could be ocular, could be nasal. So that could be chlamydia, bordetella, mycoplasma, especially if it's ocular. Or it could be a bacterial infection that's secondary to herpes virus or calicivirus, or secondary to something like a foreign body, neoplasia, tooth-root abscess, something like that. So it's usually mucopurulent discharges that are the tip-off that we need an antibiotic. If we have primarily serous discharges, ocular or nasal, I'll hold off on the antibiotic. So I'll wait and see if we actually need it. We have to be ever more careful about proper use of antibiotics these days. And of course, we don't want to give a cat a drug that they don't need if they don't need it. And we don't want to ask an owner to pay for a drug if we don't have to. So if it's just a serous discharge or we don't have any discharges yet, I might hold off on the antibiotics. But if we do have mucopurulent discharges, then I'm definitely going to reach for an antibiotic. So let's talk about these three primary pathogens that are involved in the bacterial component of upper respiratory tract disease in cats. And probably the one that we're most familiar with is chlamydia. So chlamydia has gone through some name changes. Initially it was called chlamydia, then for a while there it was called chlamydophila, and now it's back to chlamydia. So you might see both types of terminology, but the current recommended or accepted terminology for this pathogen in cats is chlamydia felis. So unfortunately that has been a changing area, but we're at the point where we're calling it chlamydia felis. So again, I think of this primarily in cats like the one that you can see in this image that has conjunctivitis, sometimes quite severe with chemosis, for example, and minimal other upper respiratory tract signs. That's going to make me think of chlamydia. A typical patient is usually younger, so this is not so common in middle-aged or older cats, much more common in cats that are a year of age or younger, and more common in pedigreed breeds than it is in just the random bred domestic cats. Certainly can occur in older patients, can occur in any type of cat, but that would be the typical patient. In North America, we see less of this for some reason than in Europe. So you're more likely to see chlamydia in Europe than we are in North America. One good thing about these bacterial pathogens, unlike the viruses, we're going to talk about this in a minute, the bacterial pathogens don't persist in the environment. So we don't have to worry about environmental contamination. So that means transmission is directly cat to cat versus a cat acquiring this pathogen from the environment. So this would be a cat-to-cat transmission situation, chlamydia. One of the things that we learned about chlamydia, and we learned this, before I move on, I forgot to mention that we sometimes will see shedding for a long period of time. So speaking of that cat-to-cat transmission, once a cat is infected, we can see them shed the pathogen for weeks to months afterwards, and of course that's how it's spread to other in-contact cats. So in a multi-cat home, we might look at isolating the infected patient so we don't get in-contact shedding, although it's often occurred by the time we make the diagnosis anyway. So one thing that we did learn with regard to treatment of chlamydia, that it requires longer term treatment than we used to think in the past, although this information's been in the literature now for about 10 years, but still it's not as well recognized as I would like. So remember when I talked about acute disease, I mentioned that we would typically treat those patients for 7 to 10 days. The exception would be the patient that you think has chlamydia. So if you think your patient primarily has chlamydia, then you need a minimum of 28 days of treatment with doxycycline. So you'll see resolution of clinical signs before the 28 days, but if we want to have the best shot at eliminating the organism, which is a different thing than just treating the clinical signs, then you're best to try to get a full 28 days, so 4 weeks of treatment. And we have to remind owners about that because they will see the clinical signs clear up before the 28 days. And we have to make sure they understand that even though the clinical signs have improved, we want to do the full 28 days to have the best chance at eliminating the organism. It's not an easy organism to eliminate. So it's important to make sure owners understand that when we prescribe doxycycline for treatment of chlamydia. There is one thing I want to mention about doxycycline, and this case of mine illustrates the point, I think, quite well. This little kittie's name is Hemi, and Hemi at the time that this happened was 4 months old, little female domestic short-hair. She'd just been adopted from our local rescue group, and we saw her with a 3-day history of regurgitating her food. And in her history, we discovered that she had been treated with doxycycline at the shelter because she had upper respiratory tract disease. So her treatment had actually been a few weeks earlier, and she'd been successfully treated for the upper respiratory tract disease, but now she had regurgitation. So true regurgitation, not vomiting, but true regurgitation. And there's not a lot of things that cause that in cats. So we did some imaging. As you can see, we did some contrast imaging. So this is an esophagram. And this is barium that's been retained in her cranial, in the thoracic portion of her esophagus. Right around the level of the heart base is where it stops. And that's characteristic of an esophageal stricture. So as the esophagus passes around the heart base, there's a little bit of a point there where medications that are given in pill or capsule form can become entrapped, and they might sit there right at this location for minutes, sometimes a long time, before they actually get passed through the rest of the esophagus and into the stomach. And certain drugs will cause irritation of the esophagus as they sit in that position. And the drug that is most notorious for causing that is doxycycline. So doxycycline given with in tablet or capsule form, we have to be very careful with that because we can indeed see problems with the esophagus. The other drug that does that is clindamycin in capsule form. So doxycycline, clindamycin are the two that are notorious in cats. In people, there's a whole long list of drugs that does this. There might be more drugs in cats, but the two most notorious are doxycycline and clindamycin in cats. So we have to be very careful with those two drugs that we don't cause an esophageal stricture. And you can see here the damage to the esophagus. You can see the esophagitis. It's literally contact irritation. And over time, that inflammation might turn into fibrosis and narrow that part of the esophagus, as we saw with my patient. So whether it's doxycycline or clindamycin, it's best given in liquid form. If we have to give it as a tablet or as a capsule, we would always want to follow it with a swallow of water, with a bit of food as a treat, or there are some types of treats on the market that are meant to put pills inside. There's I don't know if you see them in Europe, but there's a brand in North America called Greenie's Pill Pockets, and it's a type of soft treat that you can hide a pill inside the treat. Whatever it is, any of these methods, we need to follow that antibiotic tablet or capsule with a drink of liquid, a bit of a food treat, something that will push the tablet or the capsule through the esophagus and down into the stomach, so it doesn't sit in the esophagus and cause that local irritation. So that's my word of advice to you about giving doxycycline or clindamycin in pill or tablet form. If you have to use those formulations, this is what we need to do. We never give those dry, in other words, without a chaser of water or food or a treat or something like that. So on that topic, I'm going to send another poll into you, and I'm going to ask you if you have ever seen a case of esophageal stricture in a cat secondary to a drug like that. So I'm always interested in how many people have encountered this. Our little patient, Hemi, needed to have that stricture dilated. So she had to have a series of endoscopic interventions where we used a balloon catheter to dilate that esophageal stricture. So they're really quite difficult to treat once you see them. And so obviously what we would like to do is make sure that we prevent them by giving our at-risk medications, the doxycycline and the clindamycin, either in liquid form or following it with water or with food. Okay, so it looks like most of you have voted now, and we had a couple of you that said yes, you have indeed seen a case like that. So I'm glad I had the opportunity to show that to the rest of you then. Okay, so we ended up, we left talking about chlamydia. Let's move on and talk about mycoplasma. There's lots of mycoplasma species in cats. The one that we're concerned about in this context is Mycoplasma felis. So a lot of mycoplasma species are normal inhabitants of the feline respiratory tract. And so we certainly do see patients that are infected but don't have clinical signs. So why some cats get clinical signs and others don't, we don't really know. This will primarily cause conjunctivitis, maybe a mild sneezing and rhinitis. It doesn't tend to make cats terribly sick, although obviously younger kittens are always going to be more at risk of more severe disease than older cats. It is difficult to culture. We can detect this on PCR, but it's very difficult to culture. Now, one of the important things to remember about mycoplasma, so if you have a patient with primarily conjunctivitis, you might think it could be chlamydia, it could be mycoplasma. We always want to choose doxycycline orally for those patients. Mycoplasma is resistant to the beta-lactam antibiotics like amoxicillin, for example, because it doesn't have a cell wall. So the beta-lactam antibiotics like amoxicillin work against bacteria that have a cell wall, and that's not mycoplasma. So that's another reason why doxycycline would be our drug of first choice, because it will treat mycoplasma. So that's what we might think of if we see a cat primarily with conjunctivitis. You might not know if it's chlamydia or mycoplasma, but if you choose doxycycline, you're going to be on the right track no matter what. And the third one that can be a primary pathogen that we'll talk about is Bordetella. So in the past, we certainly thought of this primarily as a dog disease, one of the causes of what we call kennel cough. But it also can be a primary pathogen in cats. Just like mycoplasma, we will see cats that are infected but don't have clinical signs. So some patients get clinical signs from this and some don't. We tend to primarily see this not in like the single cat, pet cat in a home. It's more likely to be in high density populations. Maybe the cat has been in a cat hotel. Maybe it's come from a shelter. Maybe it's in a breeder's home. Or a cat that's been in contact with a dog that has Bordetella infection causing kennel cough. So those are the scenarios where we're more likely to see Bordetella. We can see both upper and lower respiratory tract signs with this pathogen. So coughing would be the primary sign, sometimes with some sneezing. But we also can see lower respiratory tract disease. We can see a bronchopneumonia, primarily in young kittens. In older cats, it's more a cough, but we actually can see quite a severe bronchopneumonia. So you might see that more typically with breeders of pedigreed cats, for example, if they get Bordetella infection into their cattery. So both upper and lower respiratory tract signs, but cough would be the hallmark for Bordetella. So you can culture it. There are some labs that offer PCR detection. There is a vaccine available in some countries for this. And it is like the other bacteria that we've talked about, it doesn't contaminate the environment. It's shed in the oral or nasal secretion, so it's a direct contact transmission, just like the mycoplasma and just like the chlamydia. They're not involved in the environment. So we have traditionally thought of this as a dog disease, so I'm going to just poll you again, send another poll in and just ask you, if any of you ever diagnosed a case of Bordetella in a cat. One of the first cases that I ever published in the veterinary literature, which was a long time ago, was actually a case of Bordetella in a cat hotel, in a cat boarding situation. So I'm always interested to see how many of you have ever recognized that Bordetella can be a cause of respiratory tract, both upper and lower in cats, and if you've ever diagnosed a case. So far it looks like most of you are saying no, you've never diagnosed a case, so it's good to have it on your list of potential rule-outs, again, primarily with those cats that have a cough, or you would also think of it in those multi-cat situations like breeding catteries where they're seeing pneumonia cases. That would be the other scenario. So it looks like most of you have not seen a case of this in a cat. Okay, so it's good to talk about it, so you've got it on your list of possibilities. So that was a little bit of a look through the antibiotic responsive organisms. We have some brand new guidelines issued by the International Society for Companion Animal Infectious Diseases. They have a wonderful website that I've put on the screen here for you. So if you've not seen their website, please go visit them. They are publishing guidelines for treatment of different clinical scenarios. They have urinary tract guidelines, infectious disease urinary tract guidelines, for example. And just earlier this year, they published their antimicrobial use guidelines for respiratory tract disease, upper and lower respiratory tract disease in both dogs and cats. So it's a very useful document for you to look at, and that's where I've taken the recommendations that I've given you today. They've come from this set of guidelines. They were published in the Journal of Veterinary Internal Medicine, which is now a completely open access journal. I've mentioned this in previous webinars. So you can download it from the Journal of Veterinary Internal Medicine website itself, published just earlier this year, or you can go to the ISCAID website itself and look for their list of links, and you'll find it there as well. So please make sure you have a look at that really useful document that should be available as a reference in your practice. Okay, so let's just talk a little bit about testing, because we've talked about, especially some of these bacterial pathogens. Now we're going to talk about the viral ones in a little bit more in depth, but before we do, let's just take a minute and talk about testing to identify pathogens. So I mentioned that in the acute disease situation, cats that have had clinical signs for less than 10 days, we often don't focus on testing unless it's part of a larger population where it might be important to know what the pathogen is. Typically for pet cat homes, we're more likely just to proceed with supportive care and maybe some antimicrobials if it looks like there's a bacterial component. So in chronic disease situations or in large population situations where knowing the pathogen might be important, that's where we need to think about the assays that are available. And unfortunately, most of the assays that are available don't have good positive predictive values. So the likelihood that a positive result is actually the cause of your patient's clinical sign is poor with most, whether it's we're talking about culture or virus isolation or serology or PCR. Almost all of those methods don't have a really good track record for confirming the identity. So, and there's a number of reasons for that. I've already mentioned that we can see healthy cats, and this is true of the viral infections as well. We can see healthy cats that would test positive for many of these pathogens. So just testing positive doesn't mean the pathogen is the reason for your clinical signs. There's also widespread exposure to many of these pathogens anyway, and as we'll see in a minute, vaccination can interfere with some of these tests. And there's variable quality, I would say, for the assays that are out there in the different commercial labs. There's lots of reasons why these assays don't perform as well for us as we would like. So we usually will reserve our diagnostic efforts for the infectious diseases for large-scale management situations, not for that sort of individual pet home situation, because it's often not money well spent. We often don't get a good answer. So I'm talking about, again, whether you're sending in cultures, or maybe your reference lab offers a PCR panel for respiratory pathogens. Many of the large commercial labs do that now. Again, the positive predictive value of these types of diagnostic tests is not very good. And when it comes specifically to PCR panels, we know from some research that was published at least 5 years ago now that the PCR assays on these respiratory panels will detect herpes virus and calicivirus vaccine strains. So you can't always be sure that a positive test result is picking up a true field strain from a natural infection, or are they picking up the strains that are in vaccines that the patient may have been given recently. So unfortunately, it means a positive test result does not mean it is actually the cause of your patient's clinical signs, and a negative result on these assays also doesn't rule out the pathogen. So that's why I say we don't have good positive predictive values, and why we're not going to go ahead and run these assays on every patient with upper respiratory tract signs. We're going to reserve them for when we really need, with some good reason why we've got to dig down and find the cause of the clinical signs, again, maybe in a large-scale management situation. So we've spent a fair bit of time talking about the antibiotic-responsive pathogens. Let's talk now about herpes virus and calicivirus, because they do represent 80 to 90% of the cases that we will see. So I want to point out some key factors for you that are differences between herpes virus and calicivirus. We looked at some of the clinical differences, the main one being that oral ulceration tends to be associated with calicivirus, whereas corneal ulceration tends to be associated with herpes virus. Otherwise, the clinical signs for the two viruses overlap, so it's not always clear which virus is involved. Some other key differences have to do with stability in the environment. So these will persist in the environment. The good news is that herpes virus is very short-lived in the environment, only about 18 hours, so less than a day. It desiccates, it dries out, and it disappears even if you don't do any cleaning or disinfection. It will disappear from the environment. So typically it's close contact that's going to transmit herpes virus from cat to cat. The viruses, or both of these viruses are shed in secretions from the eyes, the nose, the mouth. So it's usually, for herpes virus especially, direct contact from cat to cat. Calicivirus, however, will persist in the environment for at least 4 weeks or longer. So that's the one we're more concerned about, cleaning the environment, and where a patient can get infected through the environment or a full, hands, food and water bowls, bedding, toys, things like that can be sources of infection for calicivirus, because it will persist in the environment, quite different from herpes virus. So that's a really important point to remember. Also, there's a difference in shedding patterns. So cats that get infected with herpes virus, we're going to talk more about this in a minute, tend to have intermittent shedding, whereas cats that get infected with calicivirus shed continuously. And they may shed, we're going to talk about this a little bit more, they may shed for a long time. Another big difference has to do with disinfectants. So herpes virus is very susceptible to most disinfectants. Doesn't last long in the environment, it's pretty easy to kill. Calicivirus, on the other hand, is the one we worry about more, because it does persist in the environment and it's resistant to a lot of disinfectants. And there's also a difference in their genetics, viral genetics. And this is important when it comes to developing PCR assays, and when it comes to the spectrum of disease that we see. So calicivirus has much more diverse genetics. There's a lot of field strains out there. So that means that vaccines may not always protect against every calicivirus field strain. Assays may not pick up every calicivirus strain that's out there. And we can see quite a wide spectrum of disease with calicivirus. So there are some really key differences, even though for upper respiratory tract disease, some of the clinical signs are very similar. There's some key differences we have to keep in mind for management. So I'm going to talk a little bit more about the disinfectant part of this, but before we do that, so I'm going to send another poll in, and I'm going to ask you which disinfectant you most often use in your clinic. So you might use more than one, but just pick the one you use most often, let's say. So it might be sodium hypochlorite, which is bleach. It could be one of the quaternary ammoniums. There's a variety of those on the market under different brand names. It could be potassium peroxymonosulfate. That gets sold under brand names like Virkon or Trifectant, probably some other brand names. Could be an accelerated hydrogen peroxide product. That also gets sold under a variety of brand names. Accel, A-C-C-E-L, Accel is one of the brand names. So I didn't put brand names on there because there's so many brand names that some of these go by. But these are for the common types that many people use in their veterinary practices. So I'm just interested in what you primarily use. And then we'll talk after we close the poll specifically for calicivirus, which ones we should or should not pick. Often the type of disinfectants that are going to be best for calicivirus are also ones that we would use for parvovirus. So fortunately, when we're thinking about disinfectants, we need to think about both of those viruses, and they tend to be susceptible to the same types of products that are on the market. We'll just wait another moment here to get a few more votes in. So far, the majority of you are saying that you're using sodium hypochlorite or a bleach product of some kind in your practice. Okay, and then we have a few of you who picked a quaternary ammonium, and then one or two that picked a potassium monosulfate product. Okay, so let's look specifically for calicivirus. What would we pick as a recommended or not recommended disinfectant for calicivirus? So the three that are recommended would be a potassium peroxymonosulfate product. And often you have to look at the label to see what exactly is in the product you're using. So you might want to go check which products you're using. Or an accelerated hydrogen peroxide, or bleach at a 1 in 30, at least a 1 in 30 dilution. The problem with bleach at a 1 in 30 dilution is that's pretty strong. It's irritating to hands, to mucous membranes. It's the fumes are irritating to eyes. The other two products that I've listed there are a little bit less irritating to skin and to mucous membranes. But all three of those would be recommended for calicivirus. Ones that are not recommended would be the quaternary ammoniums. So we're really moving away from those in veterinary practices because they don't tend to be very effective against calicivirus and often not parvovirus either. There are some products on the market that combine hydrogen peroxide with peracetic acid, so you might want to check your label again. That's not recommended for calicivirus. And chlorhexidine, another common disinfectant, also will not kill calicivirus. And as I mentioned, that's a very similar list that you would see for parvovirus, for example. So we have to be sure that we're using the right disinfectants in our practices. So I've talked about the common aspects, clinical aspects of herpes virus and calicivirus. Let's talk about some of the other aspects of these viral infections. So we do see a variety of corneal signs with herpes virus. So corneal ulceration, often shallow, especially early. We would detect that by staining, a fluorescein stain of the cornea. Very early on, it might have a dendritic pattern, a branching pattern, but most of us don't see these cases early enough to see that. I've actually only a few times in my career have I actually seen that dendritic pattern. So usually by the time you and I see the patient and we're staining the eye, it's got what's called a geographic pattern, and that just means it's some sort of irregular shape, like this, like in this patient. So that would be more typical. Usually shallow, but we're going to look at some examples of much more severe corneal disease. So the number one cause of corneal disease in the cat and a common cause of conjunctivitis is herpes virus. So a good rule of thumb is you would never put corticosteroids in the eye of any cat with corneal disease or conjunctivitis either. I would say it would be a very rare case that would benefit from corticosteroids. So it's a good rule of thumb to hold off on corticosteroids because corneal disease and conjunctival disease in the cat is so likely to be viral. And of course, if we have corneal disease, we'll impair the local immune response and we may make the disease worse. So we never want to put steroids in the eyes of those cats. So many of their patients will have mild or shallow ulcers like the cat in this picture, but we see a spectrum of much more serious cases. So these are some of my other patients with much more serious, sometimes melting corneal ulcers, even sometimes rupture of a globe. This kitty's actually had a globe rupture from a corneal ulcer that penetrated right through the cornea. So we do see quite a spectrum, but herpes virus is the number one cause of non-traumatic corneal disease in the cat. So we want to always keep that in mind. It's not just corneal ulceration that we see from herpes virus, but we see other manifestations as well. So this cat, for example, has uveitis, and one of the causes of uveitis in cats is herpes virus. So I always have that on my differential list. This is a cat with a corneal sequestrum. You can see the red arrow is pointing to that little black dot. And that's an area of dead corneal epithelial cells. And we believe that that is initiated by herpes virus infection. This one is fairly non-reactive. Often there's a reactive or an inflammatory response, at least initially, around that type of sequestrum. This is a cat with eosinophilic keratitis. Hopefully you can see all the little white raised plaque-like lesions, and then often coming in from the edge of the eye is neovascularization going across the sclera and then across the cornea. So that's eosinophilic keratitis. If you do a scraping of that, you'll see predominantly eosinophils. That's herpes virus as well. So we're going to use the same antiviral treatment for all of these manifestations as we would for herpes virus corneal ulcers. So we do get really quite a wide spectrum of corneal disease from herpes virus. We also sometimes can see dermatitis. So this is a patient of mine with herpes virus dermatitis. You can see it here right on the bridge of her nose. And that's a common spot. It's usually on the face. Especially in this area, sometimes on the nose itself, sometimes in this area between the nose and the upper lip. But usually somewhere on the face, you'll see the lesions of herpes virus dermatitis. It looks like a couple of other common skin diseases. So the other rule-outs for these lesions are eosinophilic granuloma complex or ringworm infection or a bacterial dermatitis. It's very ulcerative and crusting is what it looks like. And we would diagnose this on cytology or histopathology. If you do cytology of that lesion, you'll see predominantly eosinophils. So that's one of the clues that a cat has herpes virus disease. So those corneal lesions, like I just showed you in the previous slide, the eosinophilic keratitis, you'll see eosinophils, and in this skin lesion, you'll see eosinophils. That should make you think herpes virus. On histopathology, the pathologist might see what are called intranuclear inclusion bodies. They're not commonly seen, but if the pathologist does see that, that's a hallmark for herpes virus infection. You can do a PCR on cytology or histopath samples and detect herpes virus, or your lab might offer some type of immunohistochemical stain for herpes virus as well. But often it's just diagnosed by simply looking at the cytology and seeing a predominantly eosinophilic infiltration in those lesions. So that's herpes virus, and so we're going to treat it like any other herpes virus infection. We're going to use an antiviral for those cases. So the other thing I mentioned about herpes virus is this intermittent shedding, which is associated with latency. So the majority of cats that get infected with herpes virus are infected for life. Whether they have future clinical signs and shedding or not is quite variable. So about half of cats that get infected will have one episode of clinical signs, and then they'll never be sick with herpes virus again. But the other 50% will have reactivation of their infection sometime down the road. It might be months, might be years, and then they might get clinical signs and shed again. So this virus lives in the trigeminal ganglion, and it will hide there for the rest of the cat's life. So we may see reactivation both of clinical signs and in shedding if there's been some stressor or something that has impaired the cat's immune function. Maybe it's gotten sick with some other disease, maybe it's had to have a course of corticosteroids, something that's allowed reactivation of that virus. And it'll occur about 4 to 11 days after, say, a stressful event or some drug therapy, something like that. And typically that reactivated event will last a couple of weeks. Some cats will have clinical signs again, some may not, or their clinical signs might be mild, but they might shed virus again, and it might be an in-contact cat in the home that gets the clinical signs instead of the original cat. So that's one of the things that makes it often very hard to track herpes virus in a home, because this shedding can be reactivated. Therefore, it's intermittent, it's not continuous shedding, and the cat that's shedding may or may not have clinical signs at the time that they're shedding. So we do have to remember, though, that the majority of cats that get infected with herpes virus are infected for life. It's not true of calicivirus. Those cats, after infection, will shed for a long time, but they're typically eventually able to rid themselves of the infection, or at least the one case where that might not happen would be the stomatitis cats. But in terms of the upper respiratory signs, those cats usually don't have a reactivation and recurrence of shedding and clinical signs again in the future. They can get infected again, but it's not like herpes virus where we have these latent infections that will go ahead and reactivate. So let's talk about drug therapy for herpes virus. Since so much of the clinical signs are ocular, we'll talk about the topical ophthalmic drugs. Probably the one that's most widely used as an antiviral, a topical antiviral, is idoxuridine. Been around for a long time, still a good drug for herpes virus in cats. The problem is the frequency of administration, and many owners simply cannot cope with this frequency of administration. So a drop every 2 to 3 hours for the first 2 days, and then after that a drop 4 to 5 times a day. And we would typically treat a past resolution of clinical signs in those cats. Another topical antiviral that's much easier to give, because it's only given twice a day, is cidovovir. The problem is I don't know of any company that makes this in an eye drop. So it's made for intravenous use in people. So you sometimes can find a pharmacy. This is what we do in Canada and the US. We have a compounding pharmacy make this for us into an eye drop. So its downsides are that it's not commercially available as an eye drop, so you have to find somebody to make it. And it's therefore going to be often more expensive. But the benefit is it's only a twice a day, and it has been shown to be effective against herpes virus in cats. So if it's possible to get it, the twice a day administration is definitely a plus. And again, both of these drugs you would give for preferably 1 week past resolution of clinical signs is the length of time that we would treat. So we also think of some oral drugs for herpes virus. Lysine is the one you're probably most familiar with. Lysine antagonizes arginine. Herpes virus needs arginine to replicate. And lysine antagonizes it, lowers arginine levels, not to a point where it affects the cat. So the cat's plasma arginine levels stay adequate, but it reduces it just enough that it knocks back the virus's ability to replicate. So we do see reduced shedding, reduced severity of disease, and because these cats can reactivate and have clinical signs again in the future, we see fewer recurrences with patients that are on lysine. So the dose typically is for a kitten about 250 milligrams twice a day. For an adult cat, 500 milligrams twice a day orally. In a kitten, we might try to give it for a few weeks until we're sure that they've got control of their infection. For cats with chronic clinical signs, we might give it lifelong. So the length of time is your clinical judgment, but it, especially for the cats that have recurrent episodes, we would keep them on the lysine lifelong. It doesn't tend to work very well in shelter situations. So in these high population density, high stress situations, it doesn't tend to work very well. So it's best in pet cat homes where there isn't a lot of cats. That's where it tends to work the best. And it's best if it's given as an individual dose. So in other words, we can't add it to food and expect the cat to get some continuously through the day. It has to be dosed like a drug, twice a day like a drug. That seems to be how it works the best. So that is specific for herpes virus. It will not treat calicivirus. The other that we use for herpes virus that again is herpes specific, it doesn't treat calicivirus, is famciclovir. So we can use this for cats with severe corneal disease, maybe with chronic upper respiratory tract disease, with the skin disease that we talked about. So we can use it just for acute therapy, or we might use it long-term for those cats with chronic rhinosinusitis. The doses reported in the literature are quite variable, but we do have some research that says cats need quite high doses in order to get levels of the drug into body fluids. So especially for corneal disease, we need to get the drug into tears. And to get it into tears, you need 90 milligrams per kilo twice a day, some cats 3 times a day. You will see lower doses in the literature, something like 30 to 40 milligrams per kilo, but we may need to go up to 90, especially for cats with severe corneal disease, so that the drug actually gets secreted into tears. So we do have some nice papers in the literature showing some efficacy. We can use this in kittens as young as 8 weeks of age. So young kittens with severe herpes-related disease, from 8 weeks of age, we can use this drug. We can't use any of the other antivirals that are used for herpes virus in people. So we can't use acyclovir, we can't use valacyclovir. Those are toxic in cats. The only one that's safe, and we know it's safe for long-term use in the cat, is famciclovir. So that's the one that's worth looking at. So we might use it long-term in these cats that get chronic rhinitis and sinusitis. And this happens because the virus actually causes epithelial necrosis in the turbinate bones and in the sinuses. Then you can get osteolysis of those turbinate bones. And that leads to a whole cascade of events. So we start with these effects, pathologic effects of the virus, that causes a disruption in the normal mucociliary clearance function. So bacteria gets trapped in mucus in the sinuses and in the turbinate bones. And that's how we get chronic inflammation and these chronic secondary bacterial infections in these cats that have these chronic upper respiratory tract clinical signs. Very typically, these cats have had changes in their turbinate bones from herpes virus infection, and now we're stuck with these chronic inflammatory responses and this chronic bacterial infections. So that's an example of where we might use famciclovir long-term in those cats. We do have a couple of other options. This is a study that looked at comparing intranasal vaccine, which I don't think is available in Europe, but in North America we do have intranasal vaccines for herpes virus and calicivirus. And they compared that to giving cats human interferon at a high dose. So they gave interferon alpha 2B at 10,000 units per kilo. They gave it sub-Q once a day for 14 days. So these were cats with chronic upper respiratory tract infection that were in shelters. And of course in shelters, they can't adopt cats out into homes if they've got chronic respiratory tract disease. So they were trying to find a way to get rid of the clinical signs in these cats so that they could be adopted. Both treatments had a pretty good response rate. So it turns out they're small studies, so only 12 cats got the intranasal vaccine, but they all responded and they were all available to be adopted out. But 8 of the 13 cats that were treated with the human interferon also had a response and were able to be adopted out. So it may be worth looking at this high dose subcutaneous human interferon treatment as well for these cats with chronic disease. In Europe, you also have a feline interferon, interferon omega. We don't have this in North America, so I don't have any experience with this. It's not licensed for upper respiratory tract disease, although I know it does get used for it. It's licensed, depends on the country, it might be for feline leukemia or FIV. It's also in some places licensed for canine parvovirus, because what you're getting is an immunomodulatory response. For upper respiratory tract disease, we have no published data, so I can't point you to any research that would tell you how effective this is. You may know from your own experience if you've used this. Again, we don't have it in Canada, so I don't have any experience with it. So that's herpes. Let's just look at a little bit more closely at calici and some calicivirus presentations. So we can see stomatitis, gingivitis, young kittens, sometimes polyarthritis, but we also can see virulent systemic disease from calicivirus that we don't see with herpes virus. So just before I show you what that looks like, I'm just going to send another poll in and ask you if any of you have ever seen any of these virulent or hemorrhagic cases of calicivirus in any of your patients. They've mostly been reported in the US, but there has been cases reported in Europe. And I'll show you at least one paper out of Europe, and we'll look at what some of these lesions look like. So it's something that you do need to be aware of because it does not look like our garden variety calicivirus. I just wanted to make sure that you know about this, even though we're talking primarily about upper respiratory tract disease here tonight. So we'll just wait another moment here to get a few more votes in. So it looks like most of you are saying no, but a few of you are saying yes. You have seen cases of virulent, sometimes it's called virulent, sometimes it's called hemorrhagic calicivirus in cats. So a few of you did say yes, you have seen some of these cases. So let's go ahead and look at what that might be like. So these cats do not always start with upper respiratory tract diseases, but usually the very first case in an outbreak, and typically these are at least in North America, these have been outbreaks in cat-dense populations like shelters. And usually the first cat, when they trace it backwards, did have upper respiratory tract signs. But then it turns into a whole variety of clinical signs that we would never think of with calicivirus. So we see cats with edema. So this cat, you can see the facial swelling. You see some ulcerations on the skin. This is ulcerations on the ear of this cat. Ulcerations and hemorrhage from paw pads. We can see effusions, pulmonary edema. We can see hemorrhage, especially epistaxis. In some cases, we just see sudden death. We can see hepatitis, pancreatitis. So it really is a systemic infection. The mortality rate is very high. About 2/3 or more of cats die from this. And it tends to spread very quickly to in-contact cats. But the good news is it tends to burn out quite quickly. So Shelters, for example, might see a bunch of these cases in a short period of time and then it just disappears. So it seems to appear out of nowhere and then disappear. So it does not tend to spread into the general cat population. It tends to stay within whatever environment it initially presented in. Whether that's a large multi-cat home or a rescue shelter, something like that would be typical for where these appear. I just wanted to show you one of the case reports out of Europe. This was a case report from Belgium where they saw 2 cats that actually presented with this interesting sort of pustular dermatitis immediately after being spayed. So you can see these cats both have incisions because they were spayed, and they presented with this pustular dermatitis and then eventually with some ulceration on the legs, the feet, etc. One of these cats survived and one did not. So we can see some of these really unusual findings. And typically the calicivirus infection gets diagnosed on biopsy by finding calicivirus in the lesions, or at necropsy, finding calicivirus on histopath of samples from these cats. So no matter what form of calicivirus we're talking about, unfortunately, unlike herpes virus, we don't have specific drug therapies that we can use in cats. So we can use non-specific immunomodulatory treatments like perhaps interferon, antibiotics when there's a secondary infection, and then again, remember, oral ulceration is painful, so we will want analgesia for those cats, and of course supportive care, as we already talked about. So we're much more reliant on supportive care for calicivirus because we lack specific treatments in these cases. So I'm just going to finish up in the last few minutes talking about some of the other diagnostics that we might use for the chronic cases where we have to start looking at diagnostic options. So that's where we might be thinking about things like tooth root abscesses or foreign bodies or neoplasia or even nasopharyngeal polyps. There are some other infectious diseases, and one that I would think of in some cases would be fungal disease. And again, depends on where you live, whether you see any of these. These cats can have nasal discharge, but typically the tip-off is that it doesn't respond to traditional therapy, and you get facial swelling, almost a nasal deformity. So they may have sneezing and nasal discharge, but then they develop this swelling or nasal deformity with their disease. So depending on where you live, fungal disease might be something that you need to think of. We also need to think of nasopharyngeal polyps. These cats will present with sneezing, nasal discharge, stertorous breathing, very loud breathing, sometimes dysphagia, because as you can see in this image, here we're retracting the soft palate with a spay hook, and so we can see the polyp, and the polyps can be very, very large. So these are inflammatory polyps that initiate in the middle ear or the nasopharynx, and they may grow down so that they appear above the soft palate, or sometimes they appear in the external ear canal. That's the other place we sometimes see them. We don't really know what causes these. They might be as a consequence of an initial viral infection, but we don't know. So these cats won't respond to traditional treatment, but one of the big tip-offs for me is this stertorous breathing. So that always makes me think of nasopharyngeal polyps. So this cat that you can see here in this image, here we're using some forceps to get underneath. The polyp has a round head and then a long stalk or neck. So we're reaching underneath to grab the neck of the polyp and pull it out. And so here's what it looked like when we pulled it out. You can see that there's always a round head to it and then a long stalk or a neck. That's the part that it grows from. So here's the same cat after the traction removal. And if you look at her eyes, you'll see that she has Horner syndrome. So it's not uncommon for us to see Horner syndrome for a few days after traction removal of these polyps. That will go away on its own. We usually treat them with prednisolone for 7 to 10 days afterwards. Some of them, though, I'll usually try this medical traction plus prednisolone approach first. A few cats will need a ventral bulla osteotomy if they get recurrence. That's a pretty big surgery. So I'll usually try medical first for these kitties. Just a few other examples to show you how large they can be. Look at the size in this cat. They can be just humongous, again, coming out of this cat. They're usually in younger cats. Typically kittens or cats maybe up to the age of 1 or 2. I don't often see these in older cats. So you need to keep that in the back of your mind with some of these patients. So so thinking of diagnostics, some of the diagnostics that we might do would be a nasal flush. So here we are with the cat under anesthesia, where we're flushing warm saline up into the nasal passages and collecting anything that flows back out of the nose in this gauze. So we've got the endotracheal, it's hard to see in this picture, but the cat is intubated. So there's an endotracheal tube in place that, of course, is well inflated, and we're pressing, holding off the other nostril while we inject the saline into the other side. So usually somewhere between 20 to 50 mils of warm saline we will flush in there. And that's best to flush out foreign bodies, maybe flush out secretions. So it can be therapeutic. It might remove the cause of your problems. But also, we can use it diagnostically. So if there is a tumor in there, you might flush out a piece of the tumor that you can send off for analysis. Or if there's a fungal infection, a granuloma in there, you might flush out a piece of that you can send out for diagnostics. So we could look at cytology. The one thing I will tell you is that, excuse me, culturing fluid is not worth doing. It's a waste of money. You won't get a good answer on culturing the fluid on those cats. Endoscopy is becoming popular for some of these cases, especially neoplasias, foreign bodies, polyps, so both flexible and rigid endoscopy. So if your practice has a very small scope and has some experience with this, that also can be useful in working up these chronic cases and trying to find the cause. So for example, here's a cat with nasal lymphoma. So we can see the lesions of nasal lymphoma endoscopically in this cat. So we can get a biopsy of those, send it off to the lab, and get our diagnosis. That would be the most common nasal tumor we would see in cats, would be lymphoma. This was only a 4-year-old cat. In older cats, we might more likely see things like adenocarcinoma, for example. So endoscopy can be useful in these cats. Radiography would be most useful for the tooth root abscess cases or an oronasal fistula. You might see a space-occupying mass, again, that might make us think of lymphoma or adenocarcinoma or a foreign body. So those would be the type of things that radiography would be useful for. And I'll just show you a couple of cases here. So here's a cat with a chronic intermittent discharge, and you can see a foreign body here. That's actually a pellet from an air gun that got lodged in the nasal passages and caused a chronic discharge in that cat. Here's an older cat with a space-occupying lesion that turned out to be a sinus cavity tumor. So those are examples of where radiography might be helpful. Another example, this is a cat with a chronic unilateral discharge, and on oral exam, it's got a swelling where this canine tooth would be, and some other evidence of old facial injuries. And when this cat was x-rayed, it's possible to see a foreign body in the nasal cavity, and when it was removed, it turned out to be a fragment of that canine tooth. So that cat may have been hit by a car at one point, fractured the tooth, and then drove the tooth fragment up into the nasal cavity. So it is worth doing radiography on these chronic cases. Okay, a few quick words about prevention. We do want to think about vaccination, our primary prevention tool. We know that herpes virus and calicivirus are recommended as core vaccines by the World Small Animal Vet Association. But of course there's limitations to vaccination. It doesn't produce sterilizing immunity, and we will still see some cats get infected. So you might say, or owners might say, well, why do we bother if we can't 100% prevent infections? Well, there are benefits. It does protect against severe disease. So infected cats are unlikely to die from their disease, and it certainly helps us decrease viral shedding. So even if it doesn't totally prevent disease, it still has some great benefits for us. We also want to prevent transmission from cat to cat. So if a sick cat comes into your clinic, remember you need an appropriate disinfectant, and you want to minimize contact of that sick cat with areas of your clinic. So we would move that sick cat, for example, out of your waiting room pretty quickly and into an exam room. If they have to be hospitalized for treatment, we would want them in an isolation area. And if they can be treated at home instead of in your clinic, that would be preferred to minimize, especially calicivirus. Remember, it will persist in the environment. So we want to think about that cat-to-cat transmission. And when we've got new cats being introduced to a home, ideally a new cat should be quarantined to make sure they don't have upper respiratory tract signs, so they won't infect existing cats. And existing cats ideally should be up to date on their vaccinations before a new cat is introduced. Often owners don't plan that well, but if they do consult us, that's the type of recommendations we would give. Okay, so in summary, remember our initial approach to the acute disease is not likely going to be focused on diagnostics. It's more likely to be focused on therapeutics. And we'll pull out the diagnostics for the cats that fail the acute treatment and have disease for 10 days or longer. So remember that difference between acute and chronic disease and what our approach is. Chronic disease is often not curable, but it might be controllable. And we talked about, for example, using the injectable interferon or using famciclovir for those cases. And vaccination, even though it has its limitations, is very important for disease prevention and also for limiting morbidity and mortality. So as always, I'd like to thank some of my colleagues who shared some of the images that I showed you tonight, and my contact information so that you can get in touch with me if you need to follow up with anything that you've seen or ask me a question later on.